welcome. My name is Meredith Kwok. I am the Associate Director of Alumni and Constituent Relations for the program in Public Health. The UCI Public Health Lunchtime Lecture Series is back by popular demand, and this is episode 6. So thank you for joining us for the first time or returning to be with us again. I hope this finds you all healthy and well. As you may know, the intention of this series is to inform and engage our community in public health efforts happening right here in our backyard by highlighting the work of UCI public health faculty who are contributing to the COVID-19 response and beyond. All, of course, in an easy to digest manner over 30 minutes in your lunch break. So part 2 of this series dives a little deeper into the public health and social injustices issues occurring in our country right now. This is a critical time for public health on a global, local, and a campus level right now as our program is transitioning to via school. So our time here is very short. I'll introduce our speaker in just a second. After she presents, she will have a conversation with all of you. So please submit your questions using the Q&A function, not the chat, the Q&A, which you'll find below in your toolbar. This will be recorded for future viewing purposes. So without further ado, Dr. Cynthia Lakon is an associate professor for the UCI program in public health and also the interim chair for the newly formed Department of Health, Society, and Behavior in the Future School of Population and Public Health. That's a mouthful, but it's a very important title. Her research focuses on adolescent and adult social networks and the fundamental question of what are the theoretical pathways linking social relationships and health-relevant behavior? Her research explicitly addresses the structural, interactional, and functional properties of social network ties and has most notably studied both social support and social influence as mechanisms through which social network characteristics relate to substance abuse behaviors among both adolescent and adult populations. Dr. Lakon received her BS in Psychology and Pre-Med and her MPH in Community Health Sciences from UCLA and her PhD in Health Behavior from University of North Carolina, Chapel Hill. In 2006, she returned to UCLA for a postdoctoralship fellow in social networks and adolescent smoking. So the UC system is definitely in your blood, Dr. Lakon. We're lucky that you gave up those Bruins and came a little further south for the anteaters.
Oh, I like the anteaters.
Okay, better. I thought you were going to say better for a second.
I like them.
I'll let you take it away. Thank you so much for being with us.
Thank you, Meredith, for that introduction, and thank you all for being with us today. I can't see you, and I don't know who's with us today, but I thank you all for taking the time to attend and your interest. As Meredith said, I'm a social network researcher, and I'm very interested in mechanisms through which social relationships impact and shape health behaviors and health status. So how did I get interested in skilled nursing facilities in California and COVID? Obviously, COVID is top of mind for all of us, and skilled nursing facilities are a context that really have interested me because of my own personal experiences in watching my father pass away in a skilled nursing facility, and how difficult that was, and just taking note of the residents and how hard their lives appeared, and also the notion of these socioeconomic differences in neighborhoods that might affect the care and the context and the conditions that exist in these skilled nursing facilities also became something that I became aware of during that time of my own personal discovery of kind of what it's like to be in one of these facilities. So when COVID came around, I thought, I was especially kind of moved by the idea that in California, there were certain skilled nursing facilities, and also, as we know, in the state of Washington, certain skilled nursing facilities that were being disproportionately hit by COVID. But some of them were in California, and the National Guard got called in And then that really motivated me to think about doing work in this area because of my own personal experience in various skilled nursing facilities, actually doing service work as a younger person in my life and going into skilled nursing facilities and doing service projects. And so all of that has led me to want to do work in the elderly and specifically to understand kind of these contexts more. So that's sort of my segue into this talk and kind of what motivated me. So we all know that long-term care facilities are kind of places where the elderly congregate for various services, and kind of there's a disproportionate vulnerability for these elderly in these long-term care facilities to various things, including respiratory illnesses such as influenza, other common human coronaviruses like the common cold, tuberculosis, all sorts of communicable diseases it can fester in these places. These skilled nursing facilities are among the highest risk settings for the transmission of so many different diseases, including COVID-19. Among the reasons for why these elderly are so uniquely fragile in this population in these residential settings is because of, among many other reasons, the health conditions of these people. They have multiple concurrent underlying health conditions. The healthcare workers that work in many of these facilities, they actually they float around to various facilities in one sort of geographically defined area, or sometimes they come. My experience is that the healthcare workers were coming from various communities and driving long distances to get into different communities where they could do kind of part-time work in these facilities. So you end up with this, sort of assortative mixing process of people coming into all these different residential facilities and potentially spreading diseases. Another issue is the lack of proper infection control procedures in some of these skilled nursing facilities. They are subject to ratings every year. However, the regulation is probably not as stringent. I don't know, to be honest, and I haven't gotten into that area, but there is a lack of proper infection control protocols in some of these places and enforcement of them. And as of late, people in those facilities may not have enough of the PPE, the personal protective equipment, the healthcare workers and the patients alike. Other factors exacerbating the transmission of COVID and other diseases in these facilities include staff working while sick, and also recent failures to follow the necessary infection control procedures around COVID and other illnesses. So I began to think that the disproportionate vulnerability of these long-term care facility residents and the healthcare workers in them might be also affected by the social conditions surrounding the locations of these skilled nursing facilities. Social disparities in COVID-19 transmission have already been noticed across the country in many different ways. We see surging rates in low-income neighborhoods with high proportions of various underrepresented minority groups, including African Americans, Latino, immigrants, Native American communities often bear the disproportionate brunt of so many illnesses, and this is not any exception to that, unfortunately. In addition to racial inequalities in these communities, which these communities already face, and the consequences of those inequalities. These communities often struggle with issues including residential segregation, income inequality, and those two factors themselves have been associated with disease transmission of other diseases as well. As I said, I was particularly moved by the fact that the California National Guard had to come into some of these facilities, and it seemed to me kind of anecdotally when I was reading about this in the paper, and that's what sort of prompted me to look further into this, that perhaps some of the skilled nursing facilities that they went into were probably in beleaguered areas with low-income areas that already have a lot of issues, and that prompted me to kind of dig around on the California Department of Health website to see what are the numbers. I was just curious to see what are the numbers, and then lo and behold, they had all these different numbers from all the different residential or skilled nursing facilities reporting to the California Department of Health these COVID cases, because it's a reportable illness, of course. So in order to gain insight into the social conditions which exist around nursing homes, which may impact COVID transmission, what we did was we examined the number of COVID-19 cases reported from skilled nursing facilities in California, and we wanted to see if socio-spatial, as we define them, and I'll explain what that is, health disparities present in areas surrounding California skilled nursing facilities. We define these health disparities as place-based, racial, ethnic, and socioeconomic disparities in health status disproportionately experienced by low-income and minority populations. This study is premised upon a kind of a large amount of research showing the strong epidemiological evidence indicating a social gradient in health, meaning that if you live in an area with better health care and higher income, you might have better health care. And if you live conversely in an area with lower income and fewer places to access healthcare and not as good healthcare, your health outcomes will be worse. So we posited that skilled nursing facilities in impoverished areas with high proportions of minority populations and residential segregation by race, ethnicity, and socioeconomic status will show the highest rates of COVID-19 transmission. So we hypothesized that there would be key differences in the transmission of COVID-19 in these nursing facilities in California based on these socio-spatially defined disparities in the surrounding areas around these facilities. We used a novel approach, and I should have acknowledged my very worthy co-author, John Hipp, in the beginning of this. And he and Adam Boson in 2013 created an approach called identifying egohoods, in which they identify precise spatial units around a specific point, or what's called a centroid. And we did this to identify kind of the context in a circular fashion, in a 1/4 mile radius buffer around the block area of a specific skilled nursing facility. And so we did this for 1,040 nursing homes in California to examine relationships between the socio-spatial context surrounding each skilled nursing facility and the COVID-19 transmission within these facilities, as reported on for the patients and the healthcare workers or healthcare personnel. Data for the present study come from several sources. Information on the number of COVID-19 cases reported for all nursing homes in the state of California were collected from the, like I said, the website of the California Department of Health. These data are updated weekly, and we grabbed the most recent information for all models. Actually, there's been a little bit of a lag since we've worked on this, so this was as of June, I think late June, that our data are used. To obtain the geographic location and demographic information of these nursing homes, we used the 2010 long-term care facilities utilization data. This data set provides latitude, longitude points of each facility, and we placed it in the appropriate census block. We then merged the data sets on name and county of the facility. We matched 81% of them. And then of the non-matched cases with non-zero COVID cases, we were able to match many more based on address search with the facility name on the web. To account for the local context around these facilities, we used data from the US Census in 2010 and the American Community Survey in 2012, 5-year estimates. The dependent variables we looked at were the number of staff and facility personnel who had a laboratory positive COVID-19 test on the day reported to the California Department of Health. Staff and facility personnel were people who were anyone working or volunteering at the facility, including but not limited to contractors, temp, caregivers, and shared staff. It's amazing when you're in a residential facility, a skilled nursing facility, there's so many temporary workers there. So you kind of can see the probability of disease vectors being so high because there are all these different caretakers that are independent caretakers for the different residents that can be brought in, and the residents will pay for them privately. And these people are always kind of shuffling in and out because some of them need to work at different places. So you can imagine the permutations of so many people coming in and being possible vectors for disease in these places. The second dependent variable was the number of patients of the nursing facilities who had a laboratory positive COVID-19 test on the day reported to the California Department of Health. Patients with a confirmed test who subsequently recovered and met the criteria for discontinuation of isolation were not included in the count. So really these data are kind of just a cross-sectional point-in-time snapshot of the skilled nursing facilities in California. The reporting period ending June 23rd, 2020, 86% of the skilled nursing facilities in California reported data to the state health department. The count of the number of cases is reported when it's greater than 10. For values of 10 or less, the value is masked due to privacy, confidentiality, in accordance with the identification guidelines of the California Department of Health, who collected these data and then put them together in a data set. So we accounted for the masking of the dependent variable by using an imputation procedure. We're imputing missing values, but however, these cases, we know that there are somewhere between 1 and 10 cases. Therefore, we did what's called a multiple imputation approach, in which for each of these observations, we imputed a count based on a Poisson distribution with a mean of 2 cases. So we account for key characteristics of the nursing facility that might explain the level of infection, counted for various things, the number of beds in the facility. We also accounted for those on private insurance, Medicare, managed care, self-pay, Medi-Cal as a reference category. We also considered the age distribution of patients in the facility with measures of the percent of patients in the following age categories, including less than 45, 45 to 54, 55 to 64 was our reference category, 65 to 74, 75 to 84, 85 to 94, and 95 and older, just to get a sense of kind of those different age groups. The racial ethnic composition of the patients with respect to percent Black, percent Latino, percent Asian, other race, and white was the reference category. So we were trying to get a sense of kind of these facility level independent variables to describe kind of the context that might explain what kind of level of infection was observed in those facilities. Our egohood level independent measures, we account for the context around these facilities, and that's what these measures were used for. Whereas one approach would have considered placing these facilities into what's called census tracts in which they're located in, we found that a limitation of that approach, or rather Hip and Boson say that a limitation of that approach is that a facility may be located near the edge of a tract, in which case the tract is not a really valid measure of the context around the facility because it's in sort of extreme edge rather than in the middle, and then you would capture the whole context. So instead, we adopted an approach in which we precisely measured a geographically defined buffer around the facility and computed the demographic context of this area. This strategy is similar to other work measuring the area around a block as a buffer, work of Gina Lovasi et al. 2008, or as an egohood, that's Hip and Boson's work in 2013. The latter approach entails obtaining data in blocks, determining all blocks in which their centroid falls within the 1/4 of a mile buffer of the focal block, and then computing the measure of interest within that block, or within that area. So this is a picture of what we're talking about in terms of egohoods with you see the green, red, and blue circles, those are centroids. Then you have a 1/4 of a mile radius, and then you have the circular area, and that's the egohood, and it captures the context sort of symmetrically around the centroid in a circular manner. We constructed various socio-demographic variables that may be important to understanding the context surrounding these facilities and may help us explain why some of these facilities see higher levels of COVID cases in comparison to others. We accounted for racial ethnic composition with measures of percent Black, percent Latino, percent Asian, with percent white and other race as the remainder. To account for the possibility that the level of racial mixing may be important, we constructed a measure of racial ethnic heterogeneity based on the Herfindahl index of 5 racial ethnic groups: percent Asian, Black, Latino, white, and other race. We also constructed a measure of percent immigrants in the EGO-HUD. We also constructed a measure of the average household income. And finally, we wanted to understand the level of inequality in an area because we thought perhaps it may have a negative impact on healthcare provision in that surrounding area. And we measured this by creating a measure of income inequality based on the standard deviation of locked income in the buffer. So our statistical analyses, the outcome variables are counts of the number of COVID-19 cases in each nursing facility, and we therefore employed a negative binomial regression model to account for the count nature of the data, as well as the fact that this distribution tended to be over-dispersed. Given that we have imputed 50 different data sets for cases in which there were between 1 and 10 cases reported, we estimated each model on each of the data sets. The coefficient estimates are then combined by computing the average coefficient over the 50 estimated data sets, and the standard errors are corrected for uncertainty. So our results of our negative binomial regression models are reported. We report results for the models in which the outcome variable is the count of COVID-19 cases reported for cases among healthcare workers in the facility, and the second outcome variable in the model is for cases reported among the patients themselves. So here are the major results. A 15% increase in the percent self-pay patients in a facility, a 1 standard deviation increase, that's what that stands for, is associated with 24% fewer cases for patients compared to the reference category of Medi-Cal patients. So we see that with more self-pay patients in a facility, we see fewer cases for patients, which is probably a proxy of higher income level if there are more self-pay patients. And we see fewer cases. For the pardon me, age composition, we see that 1 standard deviation increase in the percent age 75 to 84 is associated with 40% more cases compared to the reference category of percent age 55 to 64. So having a higher age is associated with more cases, which makes sense. They're more fragile, and that is consistent kind of with what we know of COVID and the risk factors for COVID-19. Particularly notable is that the presence of more Black or Latino patients in a facility is associated with a higher number of cases for both patients and healthcare workers. 10% percentage point increase in percent Black is associated with 25% more cases reported among healthcare workers and 32% more cases reported among patients. So we're seeing these kind of socio-spatial differences in the cases among the healthcare workers and the patients, and also by race. A 10% percentage point increase in percent Latino is associated with 26% more cases among healthcare workers and 38% more cases among patients. Regarding the measures capturing the local 1/4 mile area surrounding the skilled nursing facility, we're seeing some strong effects based on the level of racial ethnic heterogeneity in the context or the presence of immigrants. A facility that's surrounded by 10 percentage points more immigrants experiences 38% more cases. It's a lot reported among healthcare workers and 45% more cases among patients. That's quite a lot. Likewise, if the surrounding neighborhood has a high racial ethnic heterogeneity, there will be more cases reported. In general, a standard one standard deviation increase is associated with 26% more cases among healthcare workers and 27% more cases among the patients. If the facility was surrounded by higher levels of income inequality, there are 25% more cases reported among healthcare workers. On the other hand, one standard deviation increase in percent Asian in the surrounding area is associated with about 20% fewer cases. So that went in the other direction. So overall, our findings create an interesting and distinctive and disturbing pattern of socio-spatial health disparities in COVID-19 transmission occurring among both the patients and the healthcare workers in these skilled nursing facilities in California. Even when we control for the age of the patients of these facilities, those with facilities with more Latino or Black patients still reported more cases of COVID-19, both among patients and healthcare workers. Moreover, skilled nursing facilities surrounded by areas with high proportions of immigrant populations tended to experience more cases among patients and healthcare workers alike. Moreover, facilities surrounded by areas with higher levels of racial ethnic mixing, which is also has been noted to be positively related to disease transmission. Those areas experience more cases among both patients and residents, or patients and healthcare workers. And our findings overall are suggestive of these specific racial, ethnic, and socioeconomically determined sort of socio-spatial disparities, as we call them, in COVID-19 transmission, both among patients and healthcare workers among these skilled nursing facilities that we've looked at. It'll be interesting to see over time what these data look like, and the California Department of Health continually updates them, so it's not hard to grab these data from there and look longitudinally. So it'll be interesting to see as the COVID pandemic declines, or whatever it does, what happens to these numbers for these ethnic and racially defined groups, and for these specific contexts, these specific physical locations around these skilled nursing facilities. I just wanted to end with a picture of an elderly man in one of these facilities, and I wanted it, sadly, to capture some of the alienation that I think these people feel. So I hope that future studies will continue to look at transmission of this disease in these settings, and really try to figure out how to affect change for the better, both for the residents and the healthcare workers who are really at risk in many of these settings. And I hope that further studies can illuminate how we can actually go in and intervene once studies as our own have been done, and more studies to confirm these trends over time. Thank you.
Thank you, Dr. Lakon. Like you said, grim and disturbing results, but very important work. Thank you. I think we have time for maybe one question. Mary Jean is asking, do you think the percentage of cases is at all related to populations not adapting recommended personal protection gear, masking, social distancing, or other standards?
Oh yes, I absolutely do. And I think in the beginning of this epidemic, or this pandemic rather, people didn't know exactly how this was spread, and kind of what protective gear was needed, and the amount of distance that would be needed to have a safe kind of environment, and what about the ventilation system in these places. And a lot of them are not well funded. Most of these places where this is happening and there are high levels of COVID transmission, they're not going to have the money to affect change in the ventilation system. And so, yes, I think absolutely your comment is very appropriate and very real, unfortunately.
And unfortunately, that's all the time we have for today. One of our esteemed alums, Alan Sudd, just shared an article. Alan, if you don't mind transferring that over to the chat, I think our audience would be curious to follow up on that. Thank you, Dr. Lakon, for being with us and sharing.
Thanks everyone for coming.
And thank you everyone for joining us. A follow-up email will be sent with the recording and links if you are curious to get more involved or support public health at UCI. And save the date, we have episode 7 on September 7th, again at 12:30. This is with Dr. Sora Park-Chanziri. She is a professor of epidemiology, and she'll be speaking on cancer health disparities in the time of COVID-19. So another really great discussion. So thank you again for everyone being with us. Sorry we couldn't get to all your questions. Dr. Lakon, you have quite a fan club in the chats right now.
Wow. Well, I can't see you guys, but thank you so much for coming, and I send it all back to you. Thank you, everyone.
Yeah, you have a lot of former students here. I'm sending them love.
Oh, how sweet. Well, I wish you all well. I hope you're all doing well, and thank you for coming. I don't know who's here, but I'm with you in spirit and hope you all are well and your families.
Thank you, and I echo that sentiment. So thank you everybody for being here. Thank you again, Dr. Lakon, and we'll follow up. Take care, be well, everybody.
Bye, everyone. Thank you.